The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
I wasn't too thrilled to have my name associated with this one, but I challenge you all to think about this stuff. So, are mock Met Call drills feasible? So what may a perfect mock Met Call look like? In our organisation, generally the rapid response team is given notice that it'll actually take place. In some organisations that's not always the case, and I acknowledge that. To me, it should always mimic a real rapid response team encounter, and that there's a designated location. And these can vary, as we've heard, from a patient's bedside, the bathroom, a visiting area, a simulation lab. And it will involve a real patient sometimes, an actor, a mannequin, and can just involve as simple as computer-based systems programs. There should never be a risk to our patients with a mock Met Call. There's always clear objectives and goals. It is an opportunity for learning and feedback, and that really the facilitator plays a very important role with informing and responding to the rapid response team, especially if it's on arrival. Who needs to be involved? I've stolen this diagram because I think it's very simple as to who needs to be there for a mock Met Call. It's from Stuart Gillam's paper. We've known this since 2012. That the Met team leader needs to be there, the additional doctor, should the Met team leader not have airway skills or vascular access abilities, the ward doctor, the primary nurse, the Met nurse, the scribe, the ward assistant, the nurse in charge, and of course the facilitator should be there. I've put the parent team. I think that's an interesting topic for conversation to get the parent team there. And I do say that having a mock Met Call there, if you are lucky enough to have the parent team, is the only way you may capture them. What are the barriers? So this pretty much, people can look at this and go, yeah, no, I'm not going to bother with mock Met Calls in my organisation. How hard is it to get staff released from clinical duty? The location, the geographical barriers. For us at Austin Health, we've got to go up to another building and go up, 7 flights. And do you know how hard it is to get to adults, especially to walk together and get up there in a timely fashion manner? I think we all know what I'm talking about. Experience and expertise. So something I've identified is we're all very good at rapid response, responding to Met Calls, but who's got the simulation experience and knowledge? And then sometimes we're utilising those people that have simulation experience and trying to work them with the rapid response team, when in actual fact it would be great if we had people that had both, knowledge of both. It can be unsettling for those involved, and we've already touched on how negatively this can impact on staff morale in a department, and something we should be very mindful of. It can interrupt real patient care, common comments. The cost for equipment to set it all up and the distraction from clinical duties can be costly as well. Who's got time to organise this if it's not funded? And capturing the right people, the attended rapid response team members, is always difficult. I am very fortunate. I work in an organisation that has intensivists that want to be involved, want to drive simulation training with the rapid response team. They have vision and motivation, but some of us aren't as lucky as that. So it all comes down for me that mock Met Calls can be feasible with the right experience and knowledge amongst your team. It's really important to focus on the planning, clear objectives and learning needs, run the scenario and run it well, or attend the mock Met Call and the debriefing of that is really important. And having the assessment tools, once you've established them, they're there and they can be used interchangeably between whatever scenarios that you want to run. That's all I'm going to say.